Hi, I'm Shanmugapriya, working as a lecturer in SNS College of Allied Health Science. Today we are going to see about a case presentation on hemoptysis. So the patient details are given: name John Doe, age 55 years, gender male, occupation retired accountant, diagnosis hemoptysis with underlying chronic obstructive pulmonary disease and bronchiectasis. Patient history: John Doe presented to the emergency department with a complaint of coughing up blood for the past 3 days. He had a history of 40 years, which he quit 5 years ago. He had been diagnosed with COPD and bronchiectasis 2 years ago and was being treated with inhaled bronchodilators and antibiotics as needed. He had no history of tuberculosis, cancer, or any other significant medical conditions. Past and comorbid illnesses: COPD, bronchiectasis, hypertension, hyperlipidemia. On examinations, the vital signs are blood pressure 140 per 90 mmHg, pulse rate 80 beats per minute, respiratory rate 20 breaths per minute, and temperature 37 degrees Celsius. Chest examination revealed diffuse expiratory wheezing and rhonchi in both lungs. Auscultation revealed crackles in the left lower lobe. The rest of the examination was unremarkable. Course in hospital. Initial investigations included chest x-ray, sputum culture, and complete blood count. The chest x-ray revealed a lower lobe consolidation with bronchiectasis. Sputum culture grew Haemophilus influenza. CBC, complete blood count, showed a white blood cell count of 12,000 cells per mm cube with a left shift. John Doe was admitted to the hospital for further evaluation and management. He received intravenous antibiotics, ceftriaxone and azithromycin for 14 days. During his hospital stay, he was receiving bronchodilators through or via inhaler to manage his COPD symptoms. These medications work by relaxing the muscles around the airways, making it easier for him to breathe. Common bronchodilators used to treat COPD include short-acting beta agonist SABA and long-acting beta agonist LABAs. Short-acting muscarinic antagonist SAMAs and long-acting muscarinic antagonist LAMAs. In John Doe's case, the specific bronchodilator used were not mentioned in the case presentation, but they could have been any of these medications. His doctor may have chosen to use a combination of SABAs and LABAs or LAMAs, depending on his symptoms and response to treatment. It's also possible that he was using a single inhaler containing both a bronchodilator and an inhaled corticosteroid, which is commonly referred to as a combination inhaler. These medications work by reducing inflammation in airways and improving lung function. In addition to bronchodilators, John Doe was also prescribed antibiotics to treat the bacterial infection identified in his sputum culture. Antibiotics commonly used to treat respiratory infections include amoxicillin, azithromycin, ceftriaxone. The specific antibiotic chosen by John Doe's doctor would have depended on the type of bacteria identified in his sputum culture and his medical history. Oxygen therapy was also initiated to help John Doe breathe more easily and prevent further complications related to low oxygen levels. The use of oxygen therapy is common in patients with COPD, bronchiectasis, particularly during exacerbations or when experiencing respiratory distress. The goal of oxygen therapy is to maintain oxygen saturation levels above 94%, which helps prevent further damage to the lungs and reduce the risk of complications such as respiratory failure. He was advised to quit smoking permanently. Thank you.